A 6-7-year-old man named Clifton came to me 24 months ago. He had been a postal supervisor for 38 years. Steady, dependable, the kind of man who had run the same route for decades, who knew every colleague by name, who arrived at work 15 minutes early every single morning and had never once been spoken to about his performance or his reliability. He came to me because his daughter had found him sitting on the kitchen floor at 6:30 in the morning. Not collapsed. Sitting, he had gotten up to make tea, felt the room tilt, and lowered himself carefully to the floor because he knew instinctively that standing was not something he could safely continue doing. He sat there for 4 minutes before his daughter found him. He had not cooled out. He did not want to cause a fuss. His blood pressure at the time of that episode, measured by the paramedics his daughter had called, was 211/124. He was admitted, he was stabilized, he was discharged 3 days later on 2 antihypertensive medications with a referral to cardiology and instructions to reduce his salt intake. The instructions were delivered verbally in a ward consultation that lasted 7 minutes. Nobody explained what salt was doing inside his body. Nobody explained why 67 years of ordinary salt consumption had brought him to a kitchen floor at 6:30 in the morning. Nobody sat with him and described the mechanism. He was told to reduce his salt intake the way you might be told to reduce your speed in a school zone. The instruction was clear. The reason behind it was assumed. He came to me because he wanted the reason. He was a man who had spent 38 years managing a postal route with precision, and he did not follow instructions whose rationale he did not understand. He said, "If someone can explain to me what the salt is actually doing, I will stop eating it." Nobody's explained it. They've just told me to stop. I sat with him for 40 minutes and explained it. Every mechanism, every organ, every consequence. And by the end of that conversation, he looked at me with the particular expression of a man who has just understood why the machine broke down and cannot believe it was allowed to run that way for so long. He said, "I wish someone had told me this." At 50, I'm Dr. Kevin Adewale. I'm a cardiothoracic surgeon. I've spent over 30 years operating on hearts, repairing arteries, and watching what chronic sodium overload does to the human body organ by organ, year by year, in a process so gradual and so silent that by the time it announces itself, it has already done its worst work. What I'm about to share with you, most doctors won't bring up at your annual checkup. But after 60, it matters more than you think. Today, I'm going to explain exactly what happens to your body when you eat too much salt after 60. Not in the general reduce your sodium kind of way that every health leaflet contains, in the specific mechanistic organ-by-organ way that Clifton needed and did not receive. I am going to take you through what excess sodium does to the kidneys, to the blood vessels, to the heart, to the brain, and to the bones. And then I am going to give you something specific to do about it. Stay with me, because the organ I describe third is the one that surprises people most. And it is the organ whose sodium-related damage is the most silent, the most cumulative, and the most irreversible. Before I take you through the 5 systems that excess salt damages after 60, I need you to understand something about sodium and the aging body that most people have never been told. Because the conventional understanding of salt and health. 4. Salt raises blood pressure. Reduce your salt intake is correct but incomplete. It does not explain why the same amount of salt that caused no measurable problem at 40 becomes a cardiovascular emergency. At 67, it does not explain why the instruction to reduce salt intake feels arbitrary when the person has been eating the same amount their entire adult life without obvious consequence. And it does not explain what is actually happening inside the body that makes salt specifically and increasingly dangerous as the body ages. Think of it this way. Sodium is not an enemy. It is an essential mineral. Every cell in your body depends on the sodium-potassium gradient across its membrane to function. Every nerve impulse, every muscle contraction, every heartbeat requires precise sodium management at the cellular level. The body is extraordinarily sophisticated in its sodium regulation. A complex orchestration of kidney tubular function, hormonal signaling through the renin-angiotensin-aldosterone system, and autonomic nervous system inputs that together maintain serum sodium within a narrow and critical range under almost all circumstances. The problem is not sodium. The problem is the salt processing capacity of an aging body. At 40, the kidneys filter approximately 180 liters of fluid per day. By 67, in the absence of any specific kidney disease, that filtration rate has fallen by approximately 25 to 30%, simply through the normal biology of aging. Nephrons are not replaced when they wear out. They are lost permanently. By the 7th decade of life, most adults have lost a meaningful proportion of their nephron population, and their remaining nephrons are compensating by hyperfiltrating, working beyond their designed capacity. That reduced filtration capacity means sodium is cleared from the bloodstream more slowly. Excess sodium stays in the circulation longer. Its effects on blood pressure, on the arterial wall, on the heart, and on every organ that depends on adequate blood flow are sustained for longer than they were at 40. The same dietary sodium load that was processed and excreted efficiently by the 40-year-old kidney sits in the bloodstream of the 67-year-old kidney for hours more, driving blood pressure, driving vascular inflammation, driving the cascading consequences I am about to describe, simply because the machinery responsible for clearing it has lost a quarter of its capacity through the entirely normal passage of time. This is why the same diet becomes dangerous later. Not because the food changed, because the body changed. And because nobody updated the dietary assessment to reflect the body that was now processing it. The first system damaged by excess salt after 60 is the one most people know about but do not fully understand. The kidneys. Not simply because the kidneys manage sodium, but because the relationship between excess sodium and kidney damage is a vicious cycle. The more salt the kidneys process, the more damage they sustain, and the more damage they sustain, the less able they become to process the next load of salt. Here is what is actually happening inside the body. When excess sodium arrives in the bloodstream, the kidneys respond by trying to excrete it. The glomeruli, the tiny filtration units of which there are approximately 1 million in each kidney, increase their filtration pressure in an attempt to push more sodium out of the blood and into the urine. This elevated filtration pressure is called glomerular hypertension. It produces results in the short term. Sodium is excreted, blood pressure falls slightly. But sustained glomerular hypertension damages the glomerular membranes themselves. The fine filtration architecture of the glomerulus, a structure of extraordinary delicacy and precision, capable of filtering molecules down to specific size thresholds while retaining everything larger, begins to lose its integrity under the repeated mechanical stress of elevated filtration pressure. Proteins that should be retained in the bloodstream begin to leak through into the urine. Proteinuria develops. And proteinuria, once established, is itself a driver of further glomerular damage. The protein in the tubular fluid is toxic to the tubular cells. Downstream, tubular inflammation follows, interstitial fibrosis develops, nephrons are permanently lost. The relationship between dietary sodium and kidney function decline has been confirmed in multiple longitudinal studies. Research published in the Journal of the American Society of Nephrology found that higher dietary sodium intake was independently associated with faster decline in eGFR over 10 years in adults over 60, an association that was present even in adults without diagnosed hypertension. The kidney damage was occurring below the threshold of clinically elevated blood pressure. The mechanism was operating quietly. The eGFR was declining, and the person was adding salt to their food without any awareness that each added gram was accelerating the loss of the filtration capacity they were relying on to process it. And the second system is the one that most people associate with salt damage and yet do not fully understand the mechanism behind the blood vessels, specifically the endothelium, the single-cell layer lining the inner surface of every artery in the body and the arterial wall architecture that becomes the site of atherosclerotic disease. Here is what is actually happening inside the arterial wall when chronic sodium excess is present. Sodium has direct effects on the endothelium that are independent of its blood pressure-raising action. High sodium concentrations in the blood directly stiffen the glycocalyx, the protective coating that lines the inner surface of endothelial cells and acts as a first barrier against the adhesion of inflammatory cells and LDL particles to the arterial wall. When the glycocalyx is damaged by high sodium, the endothelial cells beneath it become more adhesive. Monocytes, the white blood cells that initiate plaque formation when they migrate into the arterial wall and engulf oxidized LDL, adhere more readily. The initiation of atherosclerosis is facilitated. Simultaneously, high sodium directly reduces the bioavailability of nitric oxide, the primary vasodilatory compound produced by endothelial cells. Nitric oxide keeps arteries relaxed and flexible, prevents platelet aggregation, and inhibits the inflammatory signaling that drives plaque progression. When nitric oxide is reduced by the direct sodium endothelial interaction, the arteries stiffen. Blood pressure rises independently of the volume-mediated mechanism, and that stiffness measured as increased pulse wave velocity, the speed at which the heart's pressure wave travels through the arterial system, is independently associated with cardiovascular event risk, independent of the blood pressure number itself. After 60, the arterial walls are already stiffer than they were at 40. The elastic tissue that once absorbed and buffered each heartbeat pressure wave has been progressively replaced by stiffer collagen. The arteries have less reserve to accommodate the additional stiffening that sodium-mediated nitric oxide reduction produces. The same dietary sodium that produced a modest stiffening effect at 45 produces a clinically significant one at 65. And the blood pressure reading at the GP office taken at one moment on one day with one cuff does not capture the arterial stiffness that is determining what happens inside those vessels between measurements. Research published in the Journal of the American College of Cardiology confirmed that dietary sodium reduction in adults with elevated arterial stiffness produced measurable improvements in pulse wave velocity within 4 weeks, demonstrating that the arterial stiffening effect of excess sodium is reversible with reduction, and that the reversal is faster than most people anticipate. 4 weeks, the arteries respond faster than the blood pressure number suggests when the sodium load is meaningfully reduced. But the third system is where things become far more serious, and it is the one I told you about at the beginning, the one that surprises people most, the one whose sodium-related damage is the most silent and the most irreversible. The third system is the brain. Here is why this surprises people. Salt is associated with blood pressure. Blood pressure is associated with stroke. So in the indirect sense, most people understand that salt has something to do with the brain. But the specific and direct mechanisms by which excess sodium damages the brain, independently of stroke, independently of blood pressure, in ways that manifest as cognitive decline, memory impairment, and dementia are almost never discussed in a standard blood pressure consultation, and almost never appear on the information leaflet handed to the patient being discharged from a ward stay after a hypertensive episode. This is the part that Clifton needed to hear, and this is the part that changes how people understand what they are actually consuming when they reach for the salt. Here is what is actually happening inside the brain. The brain is perfused by a dense network of small penetrating arteries, vessels far smaller and more delicate than the major coronary or renal vessels. These small cerebral arteries are particularly sensitive to pressure and to the direct vascular effects of sodium excess. Chronic sodium-mediated hypertension damages these small vessels in a specific way. It produces thickening of the vessel walls, narrowing of the lumen through rich blood flows, and loss of the vessel's ability to auto-regulate, to dilate and constrict appropriately in response to changes in perfusion pressure. When autoregulation fails in the small cerebral arteries, blood flow to the brain becomes pressure passive. It fluctuates with systemic blood pressure rather than remaining stable. The brain, which requires a constant and precisely regulated blood flow to maintain neuronal function, is subjected to pressure swings that damage the delicate structures it houses. The white matter, the deep brain tissue that contains the axonal connections between neurons, is the most vulnerable to this small vessel damage. White matter hyperintensities, areas of damage visible on MRI as bright white spots in the deep brain tissue, accumulate with chronic hypertension and with the small vessel disease that sodium excess drives. Those hyperintensities are not benign. They represent areas of ischemic damage to the white matter connections that allow different regions of the brain to communicate. As they accumulate, processing speed slows. Executive function deteriorates. Memory retrieval becomes less reliable. The cognitive changes that most people attribute to normal aging, the slower thinking, the word-finding difficulty, the reduced ability to manage complex tasks, are in a significant proportion of cases the cumulative manifestation of white matter damage driven by decades of blood pressure elevation that was itself driven by decades of excess sodium. Vascular dementia, the second most common form of dementia after Alzheimer's disease, is the clinical endpoint of this process in its most advanced form. It is caused by the accumulation of small vessel disease in the brain over years and decades, and it is substantially preventable. Not entirely, but substantially. Research published in The Lancet identified hypertension as the single most significant modifiable risk factor for dementia. More significant than smoking, more significant than physical inactivity, more significant than diabetes alone, and hypertension, in a significant proportion of adults, is itself the consequence of an addressable dietary pattern. Let me ask you something. When did anyone last connect your salt intake, not just to your blood pressure, but to your future cognitive function? When did anyone explain that the salt on your plate at 67 is not just a blood pressure problem, but is a brain preservation problem? Tell me in the comments, because the number of adults over 60 who have been told to reduce salt for blood pressure reasons but have never been told about the white matter damage, the vascular dementia risk, the small vessel disease that is accumulating in their cerebral circulation with every year of salt excess, is a number that represents a profound failure of preventive communication. The fourth system affected is the heart, and here the mechanism operates through two simultaneous pathways, one hemodynamic and one structural, that together explain why chronic sodium excess after 60 produces not just elevated blood pressure readings but fundamental changes to the architecture of the heart muscle itself. Here is what is actually happening inside the heart. The volume expansion produced by sodium-mediated water retention increases the preload on the heart, the volume of blood the ventricle must fill with before each contraction. The arterial stiffness produced by sodium's direct vascular effects increases the afterload, the resistance against which the heart must pump. Both preload and afterload are elevated simultaneously. The heart is filling more and pushing harder with every beat. Under that sustained hemodynamic stress, the left ventricular wall thickens, a process called left ventricular hypertrophy. The heart muscle, like any muscle asked to work persistently beyond its comfortable load, adapts by growing larger. That growth sounds beneficial. It is not. A thickened left ventricular wall is less flexible, less compliant, and less efficient at filling with blood during the relaxation phase between beats. The diastolic dysfunction develops. The heart that looks strong on a superficial assessment is working harder, filling less efficiently and consuming more oxygen per unit of work than a heart with normal wall thickness. Left ventricular hypertrophy is one of the most powerful independent predictors of cardiovascular mortality, not simply a consequence of hypertension, an independent predictor, meaning it carries prognostic information beyond what the blood pressure reading alone conveys. and research published in the Journal of Hypertension confirmed that dietary sodium intake was independently associated with left ventricular mass index, the measure of left ventricular wall thickness, relative to body size in adults with hypertension. Higher sodium intake, greater wall thickness, greater cardiovascular risk, independent of the blood pressure number that was being recorded at clinic appointments. Clifton's echocardiogram, performed after his hospital admission, showed moderate left ventricular hypertrophy. His cardiologist noted it. Nobody connected it explicitly to the salt. Nobody explained that the heart's thickened wall was a structural record of years of sodium-driven hemodynamic overload. It was simply noted in the report and filed alongside the medications that were being prescribed to address the blood pressure that had driven it. The fifth system is the one that is least anticipated when the topic is salt. The bones, specifically the relationship between dietary sodium and calcium metabolism. A relationship whose cardiovascular implications are direct and whose long-term consequences for both bone density and arterial health operate through the same biochemical pathway. Here is what is actually happening inside the body. The kidney's handling of sodium and calcium is linked. When the kidney excretes excess sodium in the urine, it also excretes calcium. The two are cleared through related tubular mechanisms, and elevated sodium excretion drives elevated calcium excretion alongside it. Chronic sodium excess therefore produces chronic calciuria and excess calcium loss in the urine. When urinary calcium losses exceed dietary calcium intake over years, the body compensates by drawing calcium from bone-activating osteoclasts, the bone-resorbing cells, to release calcium from the skeletal reservoir into the bloodstream. Maintain serum calcium levels, bone mineral density falls, osteoporosis risk rises, and the bones that are releasing their calcium into the bloodstream are simultaneously contributing to the calcium-phosphorus imbalance that promotes vascular calcification. The deposition of calcium in arterial walls that accelerates arterial stiffness and contributes to the coronary artery calcium scores that cardiologists use to measure cardiovascular risk. The same dietary sodium excess that is raising blood pressure, damaging kidney, nephrons, stiffening arteries, driving left ventricular hypertrophy, and promoting cerebrovascular white matter disease is also dissolving bone mineral into the circulation and depositing it in arterial walls. The salt is not simply raising blood pressure, it is transferring the structural integrity of the skeleton into the walls of the vessels. And the consequence shows up simultaneously as a rising fracture risk and a rising coronary calcium score in the same person who was being told their salt intake was a blood pressure problem. Research published in the New England Journal of Medicine confirmed that higher dietary sodium intake was associated with both reduced bone mineral density and higher urinary calcium excretion in postmenopausal women, and that the association was independent of calcium intake and independent of other known osteoporosis risk factors. The salt was the variable, the bone loss was the consequence, and in the cardiovascular context, the calcium released from that bone was contributing to the arterial calcification that the same patient's cardiologists were managing as a separate problem with separate medication. Let me bring all five together. Because Clifton's body, lying on the kitchen floor at 6:30 in the morning, was the cumulative output of 5 simultaneous processes that had each been running silently for years. His kidneys, losing nephron capacity and failing to clear sodium at the rate they had managed at 40, were allowing fluid volume to expand beyond what his cardiovascular system could safely accommodate. His arteries, stiffened by sodium's direct effects on endothelial nitric oxide bioavailability and glycocalyx integrity, were transmitting each heartbeat's pressure wave with amplified force into progressively less elastic vessels. His brain's small cerebral arteries, damaged by decades of pressure fluctuation and sodium-driven vascular inflammation, had accumulated white matter damage that was reducing his cognitive reserve and his autoregulatory capacity simultaneously. His heart's left ventricular wall, thickened by years of elevated preload and afterload, was filling less efficiently and demanding more oxygen per beat than it should. And his bones were releasing calcium into his bloodstream, where it was being deposited not in his skeleton but in his arterial walls. 5. Processes. 1. Dietary pattern. 30 years of ordinary salt intake in a body that had been changing its processing capacity by approximately 1% per year, while the dietary load remained constant. The salt had not increased. The body had decreased. And the gap between what the body could safely process and what it was being asked to process had widened every year until the morning the room tilted and he sat down on the kitchen floor. Knowledge without action is just worry. I am not here to make you anxious. I am here to give you a plan. I call this the sodium reduction protocol. 5 steps beginning today. Step 1. Calculate your actual daily sodium intake this week, not by estimating, by reading labels. Every label on every processed food product you consume in a single day. Write down the sodium content per serving. Add it up at the end of the day. Compare that total to 1,500 milligrams, the target recommended by current hypertension guidelines for adults over 60 with any cardiovascular risk factor. The number you arrive at will almost certainly surprise you, because the majority of dietary sodium in the modern diet, approximately 75%, comes not from the salt shaker but from the sodium content of processed foods, breads, condiments, sauces, and prepared meals that do not taste overtly salty, but that deliver sodium in quantities that accumulate to 2 to 3 times the target before any salt has been added to anything. Step 2. Identify your 3 highest sodium sources and address them specifically this week, not all of them. 3. The 3 items from your label reading exercise that contribute at the most sodium per day. In most adults over 60 in the United Kingdom and the United States, those 3 sources are processed meats, bread and bakery products, and condiment sources. Replacing or reducing those 3 specifically will produce a greater sodium reduction than removing the salt shaker entirely, because the salt shaker typically contributes less than 20% of total dietary sodium. Step 3. Retrain your palate deliberately over 4 weeks. The perception of saltiness is not fixed. It is calibrated by exposure. A palate that has been consuming 2,000 to 3,000 milligrams of sodium daily for decades has calibrated its taste threshold to that level. Food with 1,500 milligrams of sodium per day tastes bland at first, not because it is without flavor, but because the threshold is wrong. Research from the American Journal of Clinical Nutrition confirmed that consistent reduction of dietary sodium over 4 to 6 weeks produced a measurable downward shift in the sodium taste threshold, meaning food that initially tasted undersalted became adequate and then preferred as the palate recalibrated. The blandness of the first week is not the permanent experience. It is the recalibration in progress. Step 4. Replace sodium-based flavoring with potassium-rich natural alternatives where kidney function permits. Fresh lemon juice, fresh garlic, ground cumin, coriander, turmeric, black pepper, smoked paprika, fresh herbs including basil, parsley, coriander, and thyme. These add flavor and complexity that reduces the perceived need for salt, while simultaneously providing compounds, particularly from garlic and from the polyphenol-containing herbs and spices, that have direct anti-inflammatory and vasodilatory effects on the arterial wall. The replacement is not a deprivation. It is a flavor redesign with cardiovascular benefit built in. Note, if you have kidney disease with reduced potassium excretion, discuss potassium-rich food additions with your renal team before implementing this step, for the reasons I described in a previous video. Step 5. Request a measurement of your dietary sodium intake at your next GP or cardiologist appointment and ask specifically how your current sodium intake relates to your cardiovascular risk profile. Ask for a spot urine sodium to creatinine ratio, a simple urine test that provides a reliable estimate of your dietary sodium intake without requiring a cumbersome 24-hour urine collection. That number gives your doctor the actual dietary sodium picture rather than the self-reported estimate that most dietary assessments rely on. And it gives you an objective baseline against which the reduction you implement over the next 8 weeks can be measured. The blood pressure response to meaningful sodium reduction in a sodium-sensitive adult over 60 is typically visible within 2 to 4 weeks. Measurable, real, often equivalent to the addition of a single antihypertensive medication at a standard dose. I want to come back to Clifton. After our conversation, after the 40 minutes in which I explained every mechanism I have described to you today, he made 2 changes in the first week. He read every label in his kitchen and removed the 3 highest sodium sources from his daily routine. He stopped adding salt at the table entirely. He began using lemon juice and garlic and black pepper with a discipline that a 38-year postal supervisor applies to everything he decides to do. At his 8-week blood pressure review, his systolic had fallen from an average of 162 to 141 on the same 2 medications, without any additional prescription, without any other lifestyle change beyond the sodium reduction. His nephrologist, reviewing his kidney function at the same visit, noted that his rate of eGFR decline had slowed compared to the trajectory of the previous 18 months. His cardiologist reduced one of his medications at the 12-week visit because his blood pressure was consistently below 135. He came back to see me 4 months after our initial conversation. He sat down across from me without his daughter. He had driven himself. He had not been on his kitchen floor since he asked. He placed his blood pressure log on the desk between us. He had been recording his readings every evening in the same spirit of methodical precision he had applied to everything for 38 years, and he tapped the most recent entry with one finger. It read 132/79. He looked at me, and then he said the thing that has stayed with me ever since. He said one conversation, one explanation of the mechanism. 40 minutes. He paused. Then he said, 38 years of the wrong amount, and nobody had 40 minutes to explain why. That is the cost of the instruction. Without the mechanism to reduce your salt intake, set a discharge on a leaflet. Without the biology, without the 5 systems, without the story of the kidney losing its capacity year by year, while the dietary load stayed the same, without the artery stiffening, without the white matter damage, without the bones dissolving into the vessels, without the heart thickening its wall to absorb what it was never designed to absorb permanently, you now have the mechanism, all 5 of them. Salt is not simply a blood pressure problem after 60. It is a kidney problem, an artery problem, a brain problem, a heart problem, a bone problem. It is a systemic assault on 5 major organ systems simultaneously, conducted silently over years in a body whose processing capacity has been declining at 1% per year, while the dietary load has stayed exactly where it was when their processing capacity was 30% higher. Which of these 5 systems do you feel most concerned about in your own situation today? The kidney function that has been quietly declining, the arterial stiffness that your morning blood pressure reading is reflecting, the white matter damage that may be behind the cognitive changes you have been attributing to normal aging. Tell me in the comments below. I read every single one, and those answers help me understand where the communication gap in sodium education is most consequential and most urgent to address. If this video gave you something that changes what you reach for before you eat today, share it. Not for me, for the person in your life who is adding salt to their food every meal, whose blood pressure is climbing, whose GP has told them to cut back without explaining a single mechanism, and who has been told to do something without being told why, often enough that they have quietly stopped taking the instructions seriously. They may not know what is happening inside their kidneys and their arteries and their brain every time they add salt, but you do now. And that is exactly why you are here. And if you have not subscribed yet, please do. Every week, I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. Take care of your heart. It has been working for you every single minute of every single day without asking for anything in return. Give it what it needs. It is a fair trade. One last thing, and this is important. Everything I have shared today is general medical information based on published research and my clinical experience as a cardiac surgeon. It is not a substitute for your personal medical care. Please do not make changes to your medications or your prescribed management plan without speaking to your own physician first. They know your history. They know your clinical picture. I do not. This is education. Use it as the beginning of that conversation. The conversation that Clifton wishes someone had started with him at 50.